Picture this. You're in the trauma bay. It's a Friday night, 0300 hours.
Yeah, the classic setup.
Right. You've got a patient with a severely swollen hand. Maybe it's from a punch, maybe a fall. You throw them in the scanner, pull up the x-ray on the light box, and you're tracing the cortex of the bones.
And the alignment looks, well, not terrible.
Exactly. A slight bend in a metacarpal, maybe a joint that looks a millimeter wide, but ostensibly in place.
Right.
Your instinct, especially if you're exhausted, is to just slap a splint on it, call it a sprain or a stable fracture, and send them to the outpatient clinic.
Which is completely understandable at 3 in the morning.
I mean, we've all been there. But the moment you walk away, you've potentially set that patient up for a permanently locked joint or a devastating deformity. And honestly, you've set yourself up to fail your boards.
Yeah, that is the ultimate trap in trauma and orthopedics. We are trained to trust the radiograph, to look for that jagged white line, that obvious cortical disruption.
But the hand doesn't play by the rules of the femur or the tibia.
No, not at all. The hand is this remarkably deceptive mechanical linkage. A bone can look horrifyingly deformed but function beautifully. Or conversely, a joint can look perfectly aligned on a static film while a piece of soft tissue is silently strangling the cartilage inside.
And that deception is exactly what we are dissecting in this deep dive.
For sure.
We are talking directly to you, the clinician who is likely behind the wheel right now. Or maybe you're scrubbing out of a case, prepping for the fellowship exam, the DNB Orth, the MRCS, or the EBOT.
You're busy. You can't take notes right now.
Right. You're trying to maximize your study time while keeping your eyes on the road. So we are going to do the heavy lifting for your memory. We are going to relentlessly drill the hand trauma discriminators into your brain.
Relentlessly is the word.
Because you're relying on audio, we will purposefully integrate the critical numbers, the strict exam lists, and those tiny anatomical discriminators into our conversation twice.
Yeah, if you hear a specific angulation threshold or a ligamentous boundary repeated, lock it in. That is the exam answer.
And to keep this massive landscape organized, we'll anchor our clinical scenarios to 2 defining principles of hand trauma.
Forgiveness and interposition.
Those 2 concepts really dictate everything we do in the OR versus the plaster room. When we talk about forgiveness, we're talking about the compensatory mechanics of the hand, right?
Exactly. Like, how much can a bone bend before the surrounding anatomy just fails to hide the deformity?
And interposition is the mechanical roadblock. It's the soft tissue that gets sucked into a joint space or trapped between ligament ends.
Right, turning a simple closed reduction into a mandatory open exploration.
So we constantly weigh those 2 forces against each other. Let's explore the limits of that forgiveness first.
I think we should start with that classic Friday night presentation you mentioned. The boxer's fracture.
Metacarpal neck fractures. The mechanism is almost always an axial load with a clenched fist striking a solid object.
And the wall usually wins.
Always. So the patient presents with loss of knuckle prominence and pain. We get the lateral x-ray, and we see the metacarpal head tilted volarly. The apex of the fracture is dorsal.
Right, and the immediate clinical question, and honestly the guaranteed exam question, is whether this fracture needs an operation.
And the answer hinges entirely on which specific digit is broken, because the hand distributes its forgiveness very unequally.
To understand why, you have to look proximal to the fracture site. You have to look at the carpometacarpal articulations, the CMC joints.
Right.
Because the metacarpal bones, they don't exist in a vacuum. They articulate with the distal carpal row. And the variance in acceptable angulation at the metacarpal neck is dictated purely by the mobility of its corresponding CMC joint at the base.
This is where we separate the stable central pillar of the hand from the mobile borders, isn't it?
Exactly. Let's take the index and middle finger metacarpals. They articulate with the trapezoid and the capitate, respectively.
Those articulations are deep, interlocking, and just heavily restrained by strong dorsal and volar ligaments.
Yeah, they form a highly rigid construct. They have to be rigid. I mean, think about it. When you pinch an object between your thumb and your index or middle finger, you are generating immense force.
Right.
If the index and middle CMC joints had play in them, your grip would just collapse. The base of the metacarpals would slide around. So evolutionary biomechanics gave us a rock-solid central pillar.
But the trade-off for that rigid stability at the base is an absolute lack of forgiveness at the neck.
Precisely, because there's no compensatory motion. If the index metacarpal neck heals with, say, a 20-degree volar tilt, the CMC joint cannot extend to absorb that angle.
So when the patient tries to make a fist, that dropped metacarpal head forces the proximal phalanx into an altered trajectory.
Yeah, the fingers will literally scissor over each other. or the metacarpal head will create this painful, firm mass in the palm that makes gripping a tool impossible.
The lack of CMC mobility means you must restore near anatomical alignment at the neck. So the accepted threshold for the index and middle fingers is incredibly strict.
You can accept only 10 to 15 degrees of angulation.
Okay, nailing that down for the exam.
Yeah.
For you listening, index and middle fingers only tolerate 10 to 15 degrees of acceptable angulation. I'll say that one more time. Index and middle, 10 to 15 degrees.
Anything beyond that 15-degree mark in the second or third digit, and you are taking that patient to the operating theater.
Right. Now contrast that rigid central pillar with the ulnar border of the hand.
The ring and little fingers.
Yeah. Their metacarpals articulate with the hamate. That CMC articulation is completely different, isn't it?
Oh, completely. It's a modified saddle joint with a convex-concave morphology that permits a significant arc of motion.
They function almost like built-in shock absorbers.
That's a perfect way to think of it. When you tightly grip a cylindrical object, like a hammer handle, the ulnar side of your hand cups downward. The ring and little finger CMC joints inherently flex and rotate to accommodate the shape.
They have roughly 15 to 30 degrees of native flexion and extension mobility.
Right. And because of that native mobility, they are incredibly forgiving of fractures distally. If the little finger metacarpal neck fractures and tilts, let's say 35 degrees volarly, the highly mobile CMC joint just naturally extends by 35 degrees to compensate.
So the patient maintains a perfectly flat open hand and a perfectly functional tight fist, despite the bone healing bend.
Exactly. The joint entirely masks the deformity.
Which means our operative threshold for the ulnar digits is far more generous. For the ring and little fingers, you can accept up to 30 to 40 degrees of angulation.
Solidifying that threshold for everyone. You can accept up to 30 to 40 degrees of angulation in the ring and little metacarpal necks.
Let me repeat that one. Ring and little, 30 to 40 degrees.
Now, some texts will argue you can push the little finger to 50 degrees in certain low-demand patients. But for the sake of the standardized boards, 30 to 40 degrees is your universally safe zone.
So if the scenario presents an isolated little finger metacarpal neck fracture angulated at 35 degrees, the correct action is non-operative management. But if that same 35-degree angulation is on the index finger, you intervene.
Spot on.
Let's say we have a patient right on the border, or maybe a 45-degree angulation on the little finger. We need to perform a closed reduction in the emergency department.
Which is tricky.
Very. The metacarpal head is small, it's slippery, and it's buried beneath swelling and soft tissue. You can't just grab it and bend it back. We have to utilize the native biomechanical linkages of the digit to manipulate the bone.
And this brings us to the Jahss reduction maneuver. To manipulate the metacarpal head, you must turn the proximal phalanx into a rigid lever arm.
Okay, and to do that, you have to lock the metacarpophalangeal joint, the MCP.
Right. And the key to locking the MCP joint lies in the highly specific geometry of the metacarpal head itself. It's not a perfect sphere.
Far from it. The metacarpal head is asymmetric in the sagittal plane. It's shaped like a cam.
Yes, the radius of curvature is much wider on the volar side than it is on the dorsal side. Furthermore, the collateral ligaments don't attach at the exact center of rotation. They have an eccentric origin dorsal to the central axis.
So when the finger is held straight out in extension, the collateral ligaments are relatively slack because they are running over the narrow dorsal portion of the cam.
Exactly. The joint has some lateral play. You can wiggle your fingers side to side when they're straight.
But as you flex the MCP joint, those collateral ligaments are forced to stretch and glide over the widest, most prominent volar portion of the cam shape.
They become incredibly taut, like piano wire tight. By the time you reach 90 degrees of MCP flexion, the collateral ligaments are at their maximum physiological tension.
The joint is completely locked.
There is zero lateral deviation possible, and more importantly for our reduction, the proximal phalanx is now tightly tethered to the metacarpal head.
It becomes a direct structural extension of the fracture fragment.
It does. So for the Jahss reduction, you flex the MCP joint to 90 degrees, and you also flex the PIK joint to 90 degrees to give your thumb a broad, flat surface to push against.
Okay, so that is the setup. The Jahss position utilizes the MCP and PIP joints flexed to 90 degrees.
Let's repeat the exact parameters of the Jahss position for the listeners. The MCP and the PIP must both be flexed to 90 degrees.
Repeating that again, Jahss position, MCP and PIP flexed to 90 degrees. So once you have the patient in that 90-90 posture, you place your thumb on the volar aspect of the flexed PIP joint and apply a strong dorsally directed
You're
force.
pushing straight upward.
Right, and because the MCP collaterals are completely locked over that cam, all of your upward force bypasses the joint and is transmitted directly into the metacarpal head.
Levering it out of its volar tilt and back into anatomical alignment. You literally use the finger to fix the hand.
It's a beautifully elegant maneuver. You feel the clunk, you check the fluoroscopy, and the alignment is restored. But now we have to hold it there.
And this is a major conceptual trap for trainees.
Oh, massive trap. It is so tempting to just cast the patient in the Jahss position, right? Just wrap them up in that 90-90 hook to hold the reduction.
But if you immobilize a digit with the PIP joint in 90 degrees of flexion for 3 weeks, you will create a disaster.
You will create an iatrogenic joint contracture that may never resolve.
Which means we must strictly differentiate the reduction maneuver from the long-term splinting strategy.
Okay.
Once the bone is reduced, we place the hand in the position of safe immobilization, historically known as the intrinsic plus or the Edinburgh position.
The physiological goal of this position is to combat the biological reality of ligaments. Ligaments are dynamic structures. If you immobilize them in a slack, shortened position, the collagen fibers cross-link and contract.
They shrink.
Yeah, they shrink. So when you finally take the cast off, the ligaments are too short to allow the joint to move, yielding a stiff, useless hand.
So our entire splinting strategy revolves around keeping every single collateral ligament at its absolute maximum length.
We've already established the mechanics of the MCP joint. Because of the cam shape of the metacarpal head, the MCP collateral ligaments are longest and tightest in deep flexion.
Right, so we must cast the MCP joints in a heavily flexed posture. However, the interphalangeal joints, the PIP and the DIP, have a completely different geometric architecture.
They do. The heads of the phalanges are more symmetric. They don't have that dramatic cam shape. The collateral ligaments of the IP joints actually achieve their maximum length and tension when the joint is in full 0-degree extension.
This creates an opposing physiological demand. To keep the ligaments long, the MCPs must be bent, but the IPs must be absolutely straight.
So if you put a patient in a comfortable, relaxed soda can grip cast with the MCP slightly bent and the IPs slightly bent, you are leaving all the collateral ligaments slack.
You are guaranteeing stiffness across the entire hand.
So we craft the splint to force the specific joints into their maximum tension postures. The wrist is brought back into extension to utilize tenodesis, which naturally pulls the fingers into flexion. Then we push those big knuckles deep into flexion and strap the fingers out straight.
Let's give them the exact parameters of the position of safe immobilization.
Yes, let's do it.
Wrist extended 20 to 30 degrees, MCP joints flex 70 to 90 degrees, IP joints in full extension, and the thumb abducted.
Locking those numbers in for the exam, safe position splinting requires the wrist extended 20 to 30 degrees, the MCPs flexed 70 to 90 degrees, the IP straight, and the thumb out. Let me repeat that one more time for you. Wrist extended 20 to 30, MCPs flexed 70 to 90, IPs straight, thumb out.
Visually, it looks like a duckbill, or someone making a shadow puppet of a dog against a wall.
Or the clam digger posture. Whatever visual mnemonic works for you, the underlying biomechanics must be fully understood. You are stretching the collaterals over the metacarpal cam and stretching the IP collaterals across the phalangeal condyle.
So if you only remember one thing from this section, index and middle metacarpal necks forgive little angulation, 10 to 15 degrees. Ring and little forgive a lot, 30 to 40 degrees. Reduce in the Jahss position with MCP and PIP at 90. And safe position splinting is wrist extended, MCPs flexed, IPs straight.
Perfect. That covers the territory of closed management for metacarpal neck fractures. But the reality of high-energy trauma like industrial crush injuries or severe motor vehicle accidents is that the bone often exceeds the limits of forgiveness.
Unfortunately, yes.
Let's transition into operative management. Let's say you have a patient whose hand was caught in a press machine. The X-ray shows a metacarpal shaft fracture, but it's not just a simple transverse break. The shaft is shattered into 5 distinct butterfly fragments over a 3-centimeter span.
The bone basically looks like a crushed bag of gravel.
Right. In that scenario, you have massive comminution. The structural integrity of the metacarpal column is obliterated.
There is no continuous bone to share the mechanical load. If you try to cast it, the muscular forces of the hand will simply collapse the fracture zone, shortening the fingers severely and destroying the tendon mechanics.
You have to open the hand, expose the dorsal aspect of the metacarpal, and implant a plate.
And this introduces a core concept of the AO foundation principles. The exam loves to test your understanding of hardware biomechanics.
Oh, they love it. They will give you a specific clinical scenario, describe how a plate is applied, and ask you to identify the primary biomechanical function of that plate.
Right. We categorize plate function into 4 main types:
Hmm.
compression, tension band, buttress, and bridge.
The discriminator in our crush injury scenario is the severe comminution, and specifically the lack of continuous bone. If you have a shattered segment in the middle, the solid, healthy bone on the proximal side of the fracture has absolutely no physical contact with the solid, healthy bone on the distal side.
There is a void filled with tiny fragments.
Exactly. So you span a long plate across this entire chaotic zone, anchoring screws only into the healthy cortical bone at the proximal and distal ends.
When you apply hardware in that specific manner, the plate must absorb 100% of the mechanical forces: axial, torsional, and bending, because the comminuted bone cannot share the load.
The plate is functioning purely as an extramedullary splint, bypassing the zone of injury entirely.
I know you have a great way of visualizing this.
Yeah, I always visualize this as literally constructing a bridge over a raging river. The shattered bone fragments are the chaotic water. You don't try to build your road on the water. You sink deep, solid, concrete pylons into the firm riverbanks on either side. Those are your screws in the healthy proximal and distal bone. The bridge itself simply spans over the chaos, holding the road up, completely unbothered by the turbulence below.
That is a highly accurate biomechanical analogy. And because you aren't squeezing the bone ends together, because you can't compress a void, you are relying on the principles of relative stability.
You are allowing micromotion on the fracture site, which stimulates secondary bone healing.
Exactly. Over weeks, the body forms a robust, soft callus around all those tiny butterfly fragments, eventually calcifying into a solid tube of woven bone, all while the plate holds the overall length and rotation of the digit.
So if the exam vignette describes a metacarpal fracture with comminution and explicitly states there is no cortical contact across the fracture site, your diagnostic reflex must be immediate.
A plate spanning comminution with no cortical contact functions strictly as a bridge plate.
Repeating that strict discriminator, if there is no cortical contact across the comminution, the hardware is acting as a bridge plate. Let me say it again for the driver. No cortical contact across comminution equals bridge plate. It is not compressing, it is not tension banding, it is bridging.
To briefly differentiate the distractors for the exam, a compression plate relies on solid, transverse bone ends being driven into each other to share the load and achieve absolute stability and primary bone healing.
Right.
A tension band plate is applied to the convex tension side of a bending bone to convert those distracting forces into compressive forces at the far cortex.
Got it.
And a buttress plate is used at the metaphysial-epiphyseal junction to physically hold up a fragment against shear forces, like a retaining wall holding back a hillside.
But in the shattered metacarpal diaphysis, the bridge plate reigns supreme. So if you only remember one thing here, a metacarpal plate spanning comminution with no cortical contact is functioning purely as a bridge plate.
Perfect. That covers the boundaries of bony forgiveness. But the hand is equally defined by the absolute lack of forgiveness when soft tissue rebulls.
Let's shift our focus to the joints and the pathology of interposition.
Okay, let's set up a new scenario.
Imagine a different patient rolls in. A basketball player went up for a rebound. The ball jammed the tip of their extended index finger, violently forcing the entire digit backward into severe hyperextension.
Ouch.
The main knuckle, the metacarpophalangeal joint, is dislocated. The index finger is sitting completely dorsal to the hand.
This is a classic dorsal MCP dislocation. Visually, the proximal phalanx has been driven backward and is resting on top of the metacarpal head. The finger is visibly shortened and bayoneted.
Usually, the emergency department physician will administer a digital block, wait for the anesthesia to set in, apply longitudinal traction, gently push the base of the phalanx volarly, and with a satisfying clunk, the joint reduces.
That's the textbook closed reduction.
But in this specific scenario, they pull, they push, they manipulate, and the joint feels like it's set in concrete.
It refuses to budge.
The knuckle remains proudly dislocated.
You have encountered a complex or irreducible dorsal MCP dislocation. The reason it won't reduce is not a lack of force or poor technique. It is because a physical structure has become trapped deep inside the joint space, acting as a mechanical block.
This is the essence of interposition. We need to identify the exact soft tissue structure that is causing the blockade.
To understand the block, look at the anatomy of the MCP joint. On the volar aspect, the palm side, the joint capsule is thickened into a dense, rigid fibrocartilaginous structure called the volar plate.
Its native function is to prevent hyperextension. It acts like a robust check rein on the front of the knuckle.
It is firmly, almost immovably attached to the base of the proximal phalanx distally. But proximally, its attachment to the metacarpal neck is much thinner and relatively weak.
So when that basketball violently hyperextends the finger, the proximal attachment of the volar plate fails. It tears completely off the metacarpal neck.
But because the distal attachment remains intact, as the proximal phalanx displaces dorsally onto the back of the hand, it drags the torn volar plate along with it.
The volar plate literally flips backward, like a trapdoor swinging on a hinge.
Yes.
And it gets sucked right between the metacarpal head and the base of the proximal phalanx.
It acts exactly like a rubber doorstop wedged under a heavy door. When you apply longitudinal traction to the finger trying to pull it back into place, you are actually pulling that trapped volar plate tighter and deeper into the joint space.
You are actively fighting against yourself.
The examiners love this specific pathology. They will describe an irreducible dorsal MCP dislocation and ask you to identify the primary structure blocking the reduction. They will populate the multiple choice options with the collateral ligaments, the extensor tendons, the flexor tendons, and the lumbricals.
You must bypass all those distractors. The single most common blocking structure preventing reduction is the volar plate.
Solidifying the exam discriminator here. In an irreducible dorsal MCP dislocation, the primary blocking structure is the flipped-up volar plate.
Repeating that again, the blocking structure is the flipped-up volar plate. Note that collateral ligaments and extensor tendons are not the blocking structures.
Now, there is a very famous, eponymously named variant of this injury that the boards frequently test. It represents the most severe manifestation of a complex dorsal MCP dislocation.
The Kaplan lesion.
The Kaplan lesion. It typically involves the index finger. The pathophysiology begins the exact same way. The volar plate tears proximally and flips into the joint. But in a Kaplan lesion, the anatomy gets profoundly tangled.
The volar plate doesn't just act as a doorstop, it gets buttonholed.
Meaning the metacarpal head is violently driven completely through a rent in the volar capsule and the surrounding fascial structures. The bone plunges deep toward the palm, becoming incarcerated.
And you need to know the exact anatomical borders of the trap holding the metacarpal head hostage.
You do. The metacarpal head is caught in a noose, with the volar plate trapped between two specific ligamentous structures. The superficial transverse metacarpal ligament proximally and the natatory ligament distally.
Let's break those down. The superficial transverse metacarpal ligament runs across the palm, connecting the palmar fascia. When the metacarpal head plunges volarly, this ligament ends up sitting tightly across the proximal neck of the dome.
Right.
And the natatory ligament, which spans the web spaces between the fingers, ends up draped tightly across the distal aspect of the trapped head.
Let's repeat those two vital boundaries for the exam. In a Kaplan lesion, the metacarpal head is trapped between the superficial transverse ligament proximally and the natatory ligament distally.
One more time for good measure. The structures are the superficial transverse ligament proximally and the natatory ligament discally. The visual of this is striking, even though we're strictly audio here. Because the metacarpal head has plunged so deeply between these tight fascial bands, it drags the overlying palmar skin down with it, creating a deep pathognomonic pucker or dimple in the palm.
And the finger itself is slightly flexed and deviated ulnarly, driven by the tension of the displaced flexor tendons and lumbrical muscles, which have also bowstrung around the trapped metacarpal neck.
The mechanics of the Kaplan lesion are so tight that any attempt at forceful closed reduction will likely cause further iatrogenic cartilage damage or fracture the metacarpal head.
It is a strict indication for the operating theater.
Which brings us to an epic, high-yield exam trap regarding the surgical approach.
Oh, this is a big one.
I mean, let's think about this. We have a pathology defined by the volar plate, a structure that fundamentally belongs on the palmar aspect of the hand. We have a metacarpal head plunging toward the palm, creating a dimple in the palmar skin.
The clinical presentation screams for a volar approach.
Exactly. Your instinct is to make a zigzag incision right over that palmar dimple, dissect down, and free the trapped bone. But wait, if you select a volar approach on the exam, you fail the question. And in real life, you risk devastating the patient's finger. Why?
To understand the danger, you have to visualize the three-dimensional displacement of the neurovascular bundles in a Kaplan lesion. Normally, the digital arteries and nerves run safely alongside the flexor tendons. But when the metacarpal head buttonholes through the fascial noose and plunges volarly, it physically pushes the neurovascular bundle out of the way.
It tensed the digital nerve tightly over the prominent displaced metacarpal head, pushing it directly toward the palmar skin.
If you make a palmar incision, you are cutting blindly through skin and fat directly toward a digital nerve that is stretched taut over a bony prominence, completely displaced from its normal anatomical safe zone. The risk of transecting the nerve is astronomically high.
That makes sense.
Furthermore, even if you successfully navigate the nerve, the structure you actually need to release, the volar plate, is not in the palm anymore. It flipped backward and is sitting on the dorsal aspect of the joint.
You're literally digging through the palm looking for a structure that has migrated to the back of the hand.
Precisely, which is why the gold standard treatment for an irreducible dorsal MCP dislocation, including the Kaplan lesion, is an open reduction via a dorsal approach.
Nailing that down for the listener. You must treat a complex MCP dislocation using a dorsal approach to access the volar plate. Repeating that. Dorsal approach to split the volar plate.
When you make a dorsal longitudinal incision, you split the extensor tendon and you are immediately looking straight down into the joint. You will see the shiny, white cartilaginous surface of the displaced volar plate staring right back at you, completely blocking the metacarpal head.
And the release is incredibly straightforward. You take a scalpel and make a simple longitudinal split right down the midline of the trapped volar plate.
That longitudinal split completely releases the tension of the noose. The trapdoor opens, the natatory and transverse ligaments relax, and the metacarpal head effortlessly slides back into anatomical position.
It's a surgical magic trick, provided you choose the correct door to enter. So, if you only remember one thing here, an irreducible dorsal MCP dislocation, including the Kaplan lesion, is blocked by an interposed volar plate, and you free it through a dorsal approach.
The mechanics of interposition are unforgiving.
Indeed. So let's pause for a quick mid-episode review. We've thrown a lot of numbers out there. If you're behind the wheel, just listen to these review points to consolidate the first half.
Metacarpal neck angulation. Index and middle, 10 to 15 degrees. Ring and little, 30 to 40 degrees.
J's reduction. MCP and PIP flex to 90 degrees.
Safe position. Wrist extended, MCP's flexed, IP's straight. That keeps the collaterals long.
Comminution with no cortical contact. Bridge plate.
Irreducible dorsal MCP dislocation. Or the Kaplan lesion, blocked by interposed volar plate, use a dorsal approach.
All right, let's keep moving. That theme of unforgiving anatomy continues as we move our focus from the digits down into the carpus.
The carpal bones are essentially a tightly packed cobblestone street at the base of the hand. Most of the pathology here focuses on the scaphoid or the lunate, but there is one specific, tiny prominence on the ulnar side of the wrist that causes disproportionate misery for athletes.
The hamate, specifically the hook of the hamate, or the hamate.
It is a small, bony projection that points volarly, jutting right up into the fleshy heel of the hand on the pinky side, the aponeurosis eminence.
We often refer to pathology here as the golfer's bane.
The mechanism of injury is highly specific. When a golfer takes a swing, the butt end of the golf club rests precisely against the base of the aponeurosis eminence, directly over the hook of the hamate.
The same applies to a baseball player gripping a bat or a tennis player holding a racket.
As they generate massive rotational force through the swing, and particularly when the club suddenly decelerates, like taking a deep divot in the turf or checking a baseball swing, an immense shear force is driven straight through the handle of the club and directly into that bony hook.
And the hook simply shears off at its base. The patient presents with deep, vague, ulnar-sided palm pain. They have profound weakness in their grip, and they physically cannot swing a club or a bat without excruciating pain.
The diagnosis is often missed initially because the hook is difficult to visualize on a standard PA X-ray. It's hidden by the overlapping carpal bones.
Right, you need a dedicated carpal tunnel view, or ideally a CT scan, to truly define the fracture.
But once we diagnose it, we encounter the biological problem of the hamate. Much like the scaphoid on the radial side, the hook of the hamate suffers from a tenuous, retrograde blood supply.
The intraosseous vessels often enter at the distal tip of the hook and flow backward toward the base.
Right, so when the bat or the club shears the hook off at the base, it completely severs the blood supply to the fragment.
The biological environment for healing is basically destroyed. Consequently, conservative management, just casting the wrist, has a shockingly high rate of non-union. The bone dies and refuses to bridge.
You are left with a jagged, mobile shard of dead bone floating in the palm, and that unhealed fragment creates a cascade of devastating secondary complications.
So it causes three main problems.
First is the unrelenting mechanical pain with any grip activity. Second is neurological. The hook of the hamate forms the lateral wall of Guyon's canal.
Right. Guyon's canal is the fibro-osseous tunnel that the ulnar nerve passes through as it transitions from the forearm into the hand. It is bordered by the pisiform medially and the hook of the hamate laterally.
When the hook is fractured and displaced, or surrounded by inflammatory fibrous tissue from a non-union, it physically impinges on the ulnar nerve inside that confined tunnel. The patient will develop paresthesias, numbness, and tingling in the ring and little fingers.
Ulnaropathy. But the third complication is the most insidious and honestly the most mechanically destructive.
Attritional flexor tendon irritation. The flexor digitorum profundus tendons to the little and ring fingers run immediately adjacent to the base of the hook. A jagged, non-united fracture acts exactly like a frayed, sharp rock sitting in the middle of a rope pulley.
Every time the patient makes a fist, those tendons glide tightly over that sharp bone edge. They do it thousands of times a day.
Over months, the tendons slowly fray, weaken, and eventually snap entirely. The patient suddenly realizes they cannot bend the tip of their pinky finger.
You have taken a minor bony fracture and allowed it to evolve into a complex tendon reconstruction.
Because of these three looming threats, pain, nerve irritation, and tendon rupture, a symptomatic or non-united hook of hamate fracture mandates surgical intervention.
And this brings us to the operative decision-making. The orthopedic instinct, ingrained in every single resident, is to fix broken bones.
Always.
We want to reduce the fragment and drive a headless compression screw straight down the barrel of the hook to compress it back to the carpus.
While fixation is occasionally attempted in acute injuries in elite professional athletes, it is technically brutal. The fragment is tiny, the approach is deep, and the hardware is incredibly prominent.
Even if you achieve perfect radiographic placement, the screw head often protrudes into the hypothenar fat pad, causing persistent pain whenever the patient grips.
And because the blood supply is compromised, the failure rate of fixation is unacceptably high.
Which means the definitive, universally accepted, board-correct answer for a symptomatic or non-united hook of hamate is much simpler.
The treatment is excision of the fragment.
Locking that in for the listener. The treatment for a symptomatic or non-united hook of hamate is excision of the fragment. I will say it again. Do not fix it. Excise the hook fragment.
You make an incision over the hypothenar eminence, carefully dissect down to the bone, meticulously shell the broken hook out of its periosteel sleeve, and remove it entirely. You just throw it in the bucket.
It feels counterintuitive to throw away a piece of the carpus, but the clinical results are phenomenal.
They really are. By removing the fragment, you instantly decompress Guyon's canal, you remove the sharp edge threatening the flexor tendons, and you eliminate the mechanical source of the pain. The athlete can often return to full competitive swings in 6 to 8 weeks.
However, the operation to excise the hook is fraught with a massive anatomical landmine.
You are operating in the immediate vicinity of the ulnar nerve as it bifurcates inside Guyon's canal.
As the ulnar nerve exits the canal, it splits into two distinct branches. The superficial sensory branch travels distally to provide feeling to the pinky and half of the ring finger. If you nick that, it's a problem, but it's just numbness.
But the deep motor branch of the ulnar nerve is the lifeline of the hand. It dives sharply downward, hooking intimately around the base of the hamate, plunging deep into the palm to innervate almost all of the intrinsic muscles of the hand.
The interossei, the lumbricals of the ring and little fingers, and the adductor pollicis.
The motor branch is what allows you to cross your fingers, spread your fingers apart, and pinch powerfully with your thumb.
If you are bluntly dissecting around the base of the hamate, trying to lever out the broken hook, and your wronger blindly transects that deep motor branch, you have paralyzed the intrinsic function of the hand. You have catastrophically downgraded the patient's functional life.
The exam will test your awareness of this specific vulnerability. During the excision approach, your primary surgical directive before manipulating the bone is to identify, mobilize, and protect the motor branch of the ulnar nerve.
Repeating that critical trap for the exam, during a hamate hook excision, you must strictly protect the ulnar motor branch in Guyon's canal. Repeating again, protect the ulnar motor branch in Guyon's canal.
Identify the nerve proximally, trace it into the canal, watch it dive deep, and keep your instruments strictly within the periosteel sleeve of the hamate.
So if you only remember one thing here, a symptomatic or non-united hook of hamate fracture is treated by excision of the fragment, protecting the ulnar motor branch, not by fixation.
We have spent a lot of time on the ulnar side of the hand. Let's travel across the palm to the radial side. The thumb.
The thumb is arguably the most important digit on the hand, responsible for nearly 50% of hand function due to its ability to oppose the other digits.
And the stability of that opposition relies heavily on one crucial ligament at the main knuckle of the thumb, the MCP joint, the ulnar collateral ligament, or the UCL.
This brings us right back to our core theme of interposition blocking healing.
UCL injury goes by a couple of famous monikers. Acutely, it's skier's thumb.
A skier falls, they instinctively keep their hand wrapped around the ski pole, the pole plants into the snow, and the handle acts as a fulcrum, violently hyperabducting the thumb.
It forces the thumb radically away from the hand, applying immense valgus stress to the MCP joint and rupturing the ulnar collateral ligament.
The chronic version, caused by repetitive low-grade valgus stress over years, is gamekeeper's thumb. The historical etiology involves Scottish gamekeepers who repeatedly stretched the UCL while breaking the necks of small game between their thumb and index finger.
Regardless of whether the injury is acute or chronic, the clinical presentation is valgus instability.
When you examine the patient in the clinic, you stabilize their metacarpal and gently push the proximal phalanx radially away from the hand.
In a healthy thumb, you feel a firm, sudden endpoint as the UCL snaps tight. In a ruptured UCL, the joint just opens up like a book. It hinges loosely without resistance.
The ligament is torn. The immediate anatomical question for the board exam is, where precisely does the ligament fail? Does it tear in the middle at the proximal origin or at the distal insertion?
The biomechanics of the injury dictate a very consistent pattern of failure. The ligament almost universally avulses from its distal footprint. The UCL nearly always avulses from its distal attachment at the base of the proximal phalanx, not the metacarpal.
Repeating that strict anatomical discriminator for the listener, the thumb UCL avulses from the base of the proximal phalanx. One more time. Avulses from the base of the proximal phalanx.
Now we reach the crux of the pathology. In many parts of the body, a completely torn collateral ligament can heal relatively well with conservative management.
Right. If you tear your medial collateral ligament in your knee, you can often wear a hinge brace for 6 weeks, the ligament ends scar back together, and you avoid surgery.
But why is the thumb UCL different? Why does a complete rupture of the thumb UCL so frequently fail to heal in a cast, mandating open surgical repair?
Because of the Stener lesion. This is the ultimate example of soft tissue interposition ruining your day.
To visualize the Stener lesion, you must understand the layered anatomy of the thumb web space. The UCL lies deep, intimately hugging the bone and the joint capsule.
And directly superficial to the UCL is the massive muscle belly of the adductor pollicis, the muscle responsible for pulling the thumb tight against the index finger.
The adductor pollicis doesn't just attach to the bone via a thin cord. It is a broad, flat, tendinous sheet called the adductor aponeurosis. This aponeurosis drapes widely over the MCP joint, lying directly on top of the UCL like a thick, heavy blanket.
Remember that blanket analogy? I think of the Stener lesion like a blanket. When the skier falls and the thumb is violently hyperabducted, the UCL tears off its distal attachment at the proximal phalanx.
As the thumb bends backward, the leading edge of that adductor aponeurosis blanket slides distally, slipping completely underneath the torn, flapping distal end of the UCL.
The aponeurosis sweeps under the torn ligament.
Then, as the trauma passes and the thumb recoils back to its normal resting position, the aponeurosis blanket sweeps backward. The torn distal end of the UCL catches on the edge of the aponeurosis and flips completely backward, folding 180 degrees onto itself.
The adductor aponeurosis has effectively slid between the torn ligament and its bony footprint. Imagine you are trying to glue 2 wooden blocks together, but the moment before the blocks touch, someone slides a thick wool blanket directly between them.
The glue will never touch the wood.
That blanket is the Stener lesion. The aponeurosis physically barricades the ligament from reaching the proximal phalanx. No matter how perfectly you cast the thumb in a spica splint, the ligament cannot heal to the bone because the blanket is in the way.
And the examiners will ask you to identify the exact spatial relationship of the anatomy in this displaced state. You need to know exactly where the torn ligament is sitting relative to the aponeurosis.
The phrasing on the exam is very specific.
It is. In a Stener lesion, the displaced ligament sits proximal to the adductor aponeurosis.
Nailing that specific wording down for the exam. The displaced ligament sits proximal to the adductor aponeurosis. Repeating that again. Ligament sits proximal to the adductor aponeurosis.
Because it avulsed distally and folded backward upon itself, it now rests entirely on the proximal side of the aponeurotic blanket.
Because of this physical barrier, a true Stener lesion is an absolute indication for open surgical repair.
You must open the thumb, physically extract the folded ligament from behind the aponeurosis, and use suture anchors to tack it back down to its anatomical footprint on the proximal phalanx.
The logical question is, how often does this sweeping blanket mechanism actually occur? Is it a rare freak occurrence that we only worry about in severe polytrauma?
Far from it. A Stener lesion is remarkably common. It occurs in up to 80% of complete UCL ruptures.
Repeating that critical statistic, a Stener lesion happens in up to 80% of complete UCL ruptures, again, up to 80%.
Because the incidence is so overwhelmingly high, the modern standard of care dictates that if you examine a patient and find an unstable, completely ruptured UCL with no firm endpoint, you assume a Stener lesion is present.
You do not waste 6 weeks trying to cast it. You book the operating room.
When we do take them to the OR, we make a lazy S incision over the dorsal ulnar aspect of the thumb MCP joint. And just like the hamate excision, there are anatomical landmines we have to navigate before we even reach the aponeurosis.
The subcutaneous fat over the radial border of the hand is laced with the terminal branches of the superficial radial nerve. These tiny nerve fibers provide sensation to the back of the thumb.
They are exquisitely sensitive to traction and transection. If you hastily incise the skin and blindly retract the soft tissues, you will likely damage these branches.
The patient may regain a perfectly stable thumb, but they will develop a devastatingly painful neuroma on the back of their hand that fires electric shocks every time they reach into their pocket.
Meticulous blunt dissection is required to identify and gently retract the superficial radial nerve branches. Once you are safely deep to the nerves, you need a reliable anatomical landmark to orient yourself before you begin cutting into the aponeurosis.
The surgical pearl here is to locate the extensor pollicis longus tendon, the EPL.
The EPL tendon runs robustly down the dorsal midline of the thumb. By identifying the EPL, you establish your dorsal boundary. You then bisect slightly volarly and ulnarly, identify the adductor aponeurosis, incise it longitudinally, and retract it to reveal the flipped UCL.
It is a satisfying surgery, but it requires strict respect for the anatomy. So if you only remember one thing for the radial side of the hand, a complete thumb UCL rupture avulses from the base of the proximal phalanx, and a Stener lesion, the adductor aponeurosis interposed proximal to the torn ligament, seen in up to 80%, blocks healing and mandates open repair.
Beautifully summarized. Which brings us to our final segment of the deep dive. We're moving distally down the fingers, past the metacarpals, past the MCP joints to the middle knuckle.
The proximal interphalangeal joint, the PIP joint. This is a simple hinge joint, and it is arguably the most frequently injured joint in sports. Anyone who has played basketball, football, or volleyball has suffered a jammed finger.
The PIP joint dislocates constantly. The vast majority of the time, the force of the ball striking the fingertip drives the middle phalanx straight backward.
A dorsal PIP dislocation. The middle phalanx is sitting on top of the proximal phalanx.
Dorsal PIP dislocations, while painful, are remarkably benign. You inject a little local anesthetic, apply longitudinal traction, and they usually reduce with a satisfying pop.
Because the volar plate is usually the only structure significantly damaged and it tends to fall back into place, these injuries do incredibly well with a brief period of extension splinting followed by early bloody taping and range of motion.
They heal well, but there is always a but.
But the boards don't test the benign, common pathology. They test the subtle, dangerous variations. If you encounter a PIP dislocation that has displaced volarly, meaning the middle phalanx has dropped downward toward the palm rather than backward toward the dorsum, you are dealing with a completely different mechanical beast.
Volar PIP dislocations are rare, and they are highly treacherous. The danger lies entirely in the specific soft tissues that are destroyed when the joint drops volarly. To comprehend the danger, we have to look closely at the extensor mechanism on the back of the finger. The extensor digitorum communis tendon travels down the dorsal aspect of the proximal phalanx. Just before it reaches the PIP joint, it trifurcates. It splits into 3 distinct bands.
The central slip and 2 lateral bands.
The central slip continues straight down the midline and inserts directly into the dorsal base of the middle phalanx. Its sole job is to extend or straighten the PIP joint.
Right.
The 2 lateral bands, however, diverge and completely bypass the PIP joint, traveling down the sides of the finger to eventually merge and insert on the distal phalanx to extend the fingertip.
So picture the anatomy during a volar dislocation. The proximal phalanx remains stationary, but the middle phalanx is violently driven downward, volarly. The central slip is firmly anchored to the top of that dropping middle phalanx. Repeating that strict pathological link for the exam, a volar PIP dislocation ruptures the central slip. Repeating one more time. Volar dislocation shears off the central slip.
Immediately, the patient loses the ability to actively straighten their middle knuckle against resistance. But the true danger is not just a weak finger. The rupture of the central slip sets off a slowly evolving catastrophic imbalance in the entire extensor mechanism.
Because the central slip is gone, there is nothing pulling the dorsal base of the middle phalanx upward. The flexor tendons on the palmar side are now unopposed, so the PIP joint slowly begins to drop into a flexed posture.
As the PIP joint sits in worsening flexion over the coming weeks, the geometry of the finger changes. Those two lateral bands that bypass the joint begin to slide volarly.
They slide down the sides of the finger until they drop below the central axis of rotation of the PIP joint.
And once a tendon drops below the axis of rotation, its mechanical function flips.
Exactly. The lateral bands, which originally helped extend the finger, now act as flexors of the PIP joint. They actively pull the middle knuckle deeper into flexion.
Simultaneously, because they are pulled tight across the flexed PIP joint, they transmit all their extending force directly into the DIP joint, pulling the fingertip into rigid, harsh hyperextension.
The PIP is stuck in flexion and the DIP is stuck in hyperextension. The finger looks exactly like it's perpetually trying to push a button.
The classic boutonnière deformity.
Repeating that downstream consequence, a central slip rupture ultimately leads to a boutonnière deformity. Again, central slip rupture equals boutonnière deformity risk.
A chronic, stiff boutonnière deformity is arguably one of the most difficult problems to reconstruct in all of hand surgery. The soft tissues become rigidly contracted, the joint cartilage degrades, and salvage procedures often yield poor functional results.
Which means the definitive treatment happens in the emergency department on day one. If you recognize a volar PIP dislocation, you must treat it with profound respect. You do not just pull it, pop it back into place, buddy tape it, and send them away, or you will guarantee a boutonnière.
Because you know the central slip is ruptured. A volar PIP dislocation demands strict, continuous extension splinting of the PIP joint, often for up to 6 weeks.
You must hold that PIP joint rigidly straight to allow the central slip to scar back down to the bone, keeping the lateral bands dorsal to the axis of rotation.
Only by holding the anatomy strictly in place can you prevent the cascade of deformity.
So, if you only remember one thing here, dorsal PIP dislocations are common and benign, but a volar PIP dislocation ruptures the central slip and carries a high risk of developing a boutonnière deformity. Treat it with strict respect.
We have covered an immense amount of biomechanical territory today. Let's consolidate the key concepts before we stress test your recall.
Let's run a rapid mid-episode review for the second half of the content. Symptomatic hook of hamate fracture in a golfer.
Excise it, protect ulnar motor branch.
Skier's thumb.
Thumb UCL avulses from proximal phalanx base.
The Stener lesion anatomy.
Ligament is proximal to the interposed adductor aponeurosis.
And a volar PIP dislocation.
Ruptures central slip, risks boutonnière deformity.
That is the core pathology. Now let's see if those repetitions stuck. If you're driving, grip the wheel. We are going into the lightning round. I'm going to throw rapid-fire clinical scenarios and anatomical questions at you. We need punchy, definitive board answers.
Fire.
Patient has a boxer's fracture, index finger, metacarpal neck. What is your acceptable angulation before going to the OR?
Very little, 10 to 15 degrees maximum.
Same fracture, but it's the little finger metacarpal neck.
Much more forgiving, up to 30 to 40 degrees of angulation.
You're reducing a displaced metacarpal neck closed. What is the Jahss position setup?
Both the MCP and the PIP joints must be flexed to exactly 90 degrees to lock the collateral ligaments.
You've reduced the fracture. Now you're splinting them in the position of safe immobilization. Give me the number.
Wrists extended 20 to 30 degrees, MTPs flexed heavily to 70 to 90 degrees, and the IP joints perfectly straight in full extension. Thumb abducted.
You're in the OR. Severe crush injury, midshaft metacarpal comminution. There is zero cortical contact between the proximal and distal bone. What is the primary function of the long plate you just applied?
It is functioning strictly as a bridge plate.
A patient has an irreducible dorsal MCP dislocation. It won't reduce closed. What structure is mechanically blocking the joint?
The flipped-up volar plate.
The patient has a dimple in their palm. It's a Kaplan lesion. What two structures is the metacarpal head buttonhole between?
The superficial transverse metacarpal ligament proximally and the natatory ligament distally.
You're taking that Kaplan lesion to the OR. What is your surgical approach?
A dorsal approach to longitudinally split the volar plate and avoid the tented palmar nerves.
Golf swing injury, non-united hook of hamate treatment.
Excision of the hamate hook fragment.
What nerve are you actively avoiding during that excision?
The deep motor branch of the ulnar nerve inside Guyon's canal.
A skier's thumb. Complete UCL tear. Where does it avulse from?
The distal footprint, the base of the proximal phalanx.
You're exploring the thumb and find a Stener lesion. Where is the ligament?
The torn ligament is trapped proximal to the adductor aponeurosis.
Statistically, how likely is that Stener lesion in a complete rupture?
Extremely likely, up to 80% of the time.
A basketball player jams their finger, PIP joint dislocates volarly toward the palm. What did they just rupture?
The central slip of the extensor mechanism.
And if you fail to splint that central slip and extension, what deformity evolves over the next month?
A boutonnière deformity. PIP flexed, DIP hyperextended.
Spot on. If you hesitated on any of those scenarios, just hit the skip back button on your stereo and run through that sequence again.
Repetition builds the reflexes you need when the exam clock is ticking.
So we've covered an immense amount of ground today, circling back repeatedly to our two governing forces, forgiveness and interposition, knowing precisely how much a metacarpal bone will tolerate based on the mobility of its CMC joint,
and understanding the devastating, unyielding nature of soft tissue when the volar plate jams the knuckle, or the Stener aponeurosis blocks the thumb UCL, or the sheared central slip unbalances the entire finger.
All comes down to mechanics.
It does. But I want to leave you with one final thought to mull over, a scenario that tests the limits of everything we just discussed. We rely heavily on this clinical rule of forgiveness. We accept 40 degrees of angulation in a little finger because we trust the mobile CMC joint and the healthy surrounding soft tissues to absorb the deformity.
Right.
But consider what happens in a severe mangling crush injury, say an industrial roller accident. You have bony comminution, yes, but you also have massive soft tissue stripping, crush necrosis of the intrinsic muscles, and scarring of the tendon sheaths.
You've completely destroyed the environment.
Exactly. How does the forgiveness of a 40-degree bony angulation change when the surrounding soft tissue envelope, the tendons, the muscle bellies, the very mechanical pulleys that we rely on to compensate for that bony deformity, is completely compromised, scarred down, and rigid? Can a bone truly be considered forgiving if the soft tissue environment around it is destroyed?
That is a phenomenal clinical question. It forces you to evaluate the whole hand as an integrated system, not just a series of isolated fractures on an X-ray. It completely destroys the binary mindset of broken versus not broken. The muddy waters of hand trauma just got a lot deeper.
The rules of forgiveness assume a healthy, compliant, compensatory environment. When you take away that environment, the rules change entirely. You have to adapt.
A brilliant concept to leave on. Next time on the deep dive, we are tackling Module 7, Soft Tissue Emergencies. We'll be navigating replantation indications, ischemia clocks, high-pressure injection injuries, and the geometric complexities of fingertip flaps. It's going to be intense and highly testable.
Until then, keep replaying those Stener lesion mechanics and metacarpal angulation numbers in your head. Good luck with your revision. Keep at it.
We'll see you on the next deep dive.